All right, welcome everybody. We are going to go ahead and get started, and we're so glad to have you with us this afternoon. Again, this is our Students at Work Healthcare Spotlight Day, and this session is going to focus on medical simulation. And we have Dr. Graham Snyder and Kevin Parrish who are going to lead this session. So I'm going to go ahead and turn it over to you all.
Great, thanks for having us. We appreciate it. Just want to say I'm Kevin Parrish. I work in the Medical Simulation Center at WakeMed in Raleigh, North Carolina. I'm a registered nurse, registered respiratory therapist, and an EMT. I've been in medical simulation for the last 5.5 years, approximately. Prior to that, I was on the pediatric neonatal transport team here at WakeMed. And in my career since 1995, I've been dealing with kids and babies almost the entire time.
And I'm Graham Snyder. I work in the emergency department as an emergency room doctor and have been in simulation for quite a few years. And when I'm not doing that, I take care of sick and injured adults and children in the ER.
Excellent. So we can move on to the next slide, please. So here's kind of what we want to talk about today. Basically, we're going to review a little bit of history of how simulation came to be, what defines simulation. So how do we use it here in the hospital? Different types of simulation, from low fidelity, just task training, practicing procedures, all the way up to multi-system organ failure scenarios on a high fidelity simulator. We'll talk a little bit about how to get into the simulation career and where simulation's going in the future. So next slide, please. So Dr. Snyder, if I asked you to define what simulation is to you, well, how would you tell these kids what simulation is?
Gosh, I would say, for things like soccer, baseball, football, we all know it's really, really important to practice before the game. It's really important to warm up. It's really important to make plans and drills. And in medicine is just like that. You could just go into work like it's the big game every day, or you could simulate work. You could practice without a real patient, but pretend using a robot or some other format, pretend on what it's like to take care of a real patient and practice that and get really, really good at that. Before game day, before the real patient's in front of you.
Great. So next slide, please. And this is kind of a pictorial of who uses simulation. We have military, we have the aviation industry, and a combination of military and aviation. We also have EMS, healthcare industries that use simulation. But look at that top left picture, and those are the early days of aviation simulation, where basically you have sheet metal riveted together on top of a box, and they move that around a little bit to try to simulate flight as well as they could back in that day. And then you translate that to the picture below it, where you have that Air Force pilot sitting in the seat of the simulator, and he is fully immersed in his environment without even having to take off from the ground. Imagine the importance of the practice that he is getting right there in that seat. And guys, anybody who does any type of gaming at home, that's simulation too. So that all translates into getting a better skill. If you remember back to using your favorite game, remember the first time you played your favorite game, and look at where you are now when you play that favorite game. If it's, whatever game it is, flight simulator, you're probably doing much better now than you were when you initially started. And that's what simulation does for us, as Dr. Snyder explained. Next slide, please. So EMS has used simulation from probably the inception of the idea of, hey, we should get into a truck and go rescue people on the side of the road when they get into a car accident. These guys are the innovators of simulation, because a lot of times they don't have the budget to spend on high fidelity simulation equipment. And so they've got to make stuff up. They've got to make it up on the fly. Do you have something to say about these guys?
Well, the thing about medicine or a lot of jobs, being a pilot, being a police officer, any job where there's some degree of intensity or danger, the reality is most of the time those dangerous, scary things, they don't happen very often. They're pretty rare. But when they do happen, they're very, very important. And so if you just wanted to depend on your experience to get good at them, it would take years and years before you'd seen enough of the scary patient, the dangerous patient, before you got good at it. Versus simulation, you can just drill the scary experience again and again and again and become an expert at it. Just like in that last slide, that pilot who had to land a huge airliner in the middle of a river. This incredibly dangerous. He'll never do that again. Maybe 100 pilots would never do that again. But the one who does need to do it, the only way he can get experience is by simulating it.
Great. Next slide, please. So here we have the setting of an academic center. This is a university or some community college that has a nursing program or an allied health program where they take care of a simulated patient. And that's a great description or a depiction of a simulated patient right there. They are human looking, they are human acting as much as we can. They have pulses and breath sounds and heart tones and things like that, and blankets, things. So you can see the students there are getting the actual experience of doing the procedures with this simulator before they get to do it on a real patient. So now they can get that practice, get the feedback from their instructor. And when they see their first patient, they've already done this. So they've done it 100 times on the simulator. They kind of know what they're doing. So when they go in there to see their real patient for the first time, it's second nature. They've done it before, so they know how to do it next. So next slide, please. And we are fortunate here at WakeMed to have a hospital-based simulation center. And Dr. Snyder, maybe you can tell these guys what the difference is between an academic simulation center and a hospital-based simulation center.
So we, our simulation center, it's focused always on the patient themselves. The patient is the one who, their disease process is what creates the simulation and creates our teaching goals. So for example, if you, if you got hit by a car, well, what kind of doctor takes care of you? The answer is not just a doctor, it's a bunch of different doctors in different fields. And in reality, it's not just doctors, it's nurses. It's not just nurses, it's paramedics. And so what we do is we start with that patient. Instead of saying, hey, we're going to teach general surgeons how to simulate general surgery problems, and we're going to only teach surgeons, what we say is we're going to have the patient's hit by a car. That means I have to have a surgeon, I have to have an emergency doctor, I have to have a paramedic, I have to have nurses, I have to have a respiratory therapist. We all come together working on the robot, simulating those injuries and getting better at them together as a team.
And so I think part of the importance of it, doing it in a hospital-based situation, is we can get those post-licensure folks down into our sim center, working together, creating the communication that would happen in real life and improving on it. And then we get a chance to talk about it afterwards and say, what do you guys think went well? And maybe what would you change for the next time we did this scenario? Or what would you change in your clinical practice because of what we learned here today? The next slide, please. So here's just a basic overview of who uses simulation in healthcare. So in academia, you've got nursing schools, med schools, pharmacies, dentists, EMS, anesthesia, surgery. They all use, all those schools are using simulation. They're using kind of simulation in their own little environment, though. So you have the School of Nursing has their own sim center. You have the School of Anesthesia doing their own sim center. Whereas in the professional healthcare field like we have here, I think I alluded to it already, is we can cross discipline lines. We don't have the specific academic centers for each university acting on their own. So we can focus on that interdisciplinary education, which is so important. Next slide, please. Getting into the career, Dr. Snyder, tell us how you got into simulation.
So I took a pretty unusual route into simulation. I was just working as a doctor in the hospital, and I was teaching the younger doctors how to do procedures which are really dangerous. Surgery's just dangerous. If things go wrong, people get hurt. If they go wrong, people can die. And it was stressful for me to be the teacher with real patients. And I thought, man, it would be a lot better if we could just practice this on something other than a real patient. And technology people were just starting to develop little robots that you could do procedures on. And so what I did was I just went to our hospital and I made an argument. I'm like, hey, this is really important. We need to spend some money. Frankly, we need to spend a lot of money to buy this equipment. And then instead of getting better through experience and the lessons taught to us by patients, we can get better practicing on the robots and always with our first patient, be experts before we even start.
That's awesome. So my brief time in simulation in comparison to my career in healthcare, I was invited by some of the people who were in the sim center to apply for an open position. And so I did, and I got the opportunity, and it's been, no regrets since then. So my path has been from a clinician coming in with all the, healthcare knowledge that I brought from my past experiences and knowing how to read evidence and implement evidence-based medicine. That's my path in the simulation. But so that's an educator's kind of path. So I came in knowing a lot about healthcare, not as much as Dr. Snyder, but enough to get by. But the other path is for a sim operator, and that's more of a technical position in simulation. So those are the folks that, are tech savvy. They do the AV systems so well. They know all the connections, from one type of a cord to another. They know how to run the software and can troubleshoot software and computers much more easily than an educator would be able to, because that's their background. And so you can come at it from that aspect as well. And for simulation and gaming, that's a whole nother industry. So that there's another entry point there as well. So thank you. Next slide. Different types of simulation. We have so many different types of simulation depending on the objectives of the learners. What's your favorite type of simulation fidelity, Dr. Snyder?
Oh gosh, it depends so much for me. I mean, it depends really on what I want to teach. Lots of times I like the high fidelity simulation, meaning when we've got like a super complicated robot that will talk and have a heartbeat and have seizures, so I can teach the doctors the intellectual exercise of diagnosing and treating complex disease. But sometimes I got one simple thing I want to teach. I want to teach somebody how to use a tourniquet. And for that, I need something that looks like an arm, something that hemorrhages uncontrollably, and something where they can just practice, practice, practice. And I don't have to deal with all the complexities of computers and programming.
Awesome. And you can see on the bottom there is a picture of a Davinci machine. And that's, basically like distance learning. You have distance surgery. You can see that the surgeon is off to the side there under the A, and his patient is under the B. His assistant is under the C. So nobody is actually doing hands-on the patient at that time. But, this seems like it's a simulated event where the physician's learning how to use the machine. And that's all simulation, Yeah, we do different kinds. So that middle picture there of the baby being born, that's kind of a mid-fidelity thing, kind of task training, like the tourniquet idea that Dr. Snyder was talking about. So lots of different ways to do simulation. Next slide, please. Oh man, so decision points when you're talking about what type of simulation you want to do and what do you want to include in that. Words of advice on this?
Well, you have to pick your tool based on what you're teaching. The reality is, like, if I want to teach a person like how to interview someone who's depressed and see whether they're so depressed they need to be in the hospital, or they're just so depressed maybe they can go home and get some counseling. To do that, I can't really use a robot. It's just going to seem fake. So for that, I really need an actor to do it. Versus if I want to do something technical, like teach a person how to use an ultrasound machine to put an IV inside a blood vessel. Well, I could never use an actor.
Sure.
Actors don't like to be poked with needles, but I could certainly use a task trainer for that.
And so based on the objectives of the learning, we kind of make that decision in the planning stage of the education. And that's kind of a fun thing to use actors in place of mannequins when we can. It gives it a little bit more of a realistic environment, which we try to do in all our simulations. Is create an environment that immerses the learners in the scenario. Next slide, please. And in making the environment realistic, we try to reduce the amount of feel of simulation while making it safe for the participants. And occasionally we have folks come in that have dealt with some personal issues on specific topics. And a lot of times we have topics that are very real to people's lives. So we have to be conscious of the participants' physical and psychological safety while we're doing these. We don't want to, relive some personal tragedy, but we also want to suspend disbelief. Is one of the catchphrases we use in simulation. We want to make the environment immersive, so it feels like you're doing the real thing in real time on a real patient. And then after the simulation, Dr. Snyder, explain how important it is for reflection after a simulation.
It's absolutely, it's so important. Like the point of doing a simulation is not only to get experience, it's to get better. And so just doing it without any feedback, well, maybe you got more comfortable, but you wouldn't get better. And so one of the most important things we do is after you go through the simulated case, whether you simulate how to take care of a heart attack or a gunshot wound, afterwards we sit down and we're like, hey, well, how'd you think you did? And that's important because I like to know how much the students took in. And then I like to feed back to them. Well, these are the things that I thought you did fantastic. And these are the things to work more on next time to get better.
Great. Next slide, please. So with just a few minutes left to talk about some of the simulation, we want to get to a video as well. So these next few slides, we're kind of speed through. So in simulation, we use all kinds of props. We try to make it as real as possible. So we use real items that they would see in the real patient care areas. So here you can see oxygen delivery, a phone, if the scenario calls for that, a nurse call bell. We have code blue buttons, team response buttons, and you can move to the next slide, please. This is an environment that was created to simulate a house fire. And so we can pump in smells and noises and all those things that would make it feel more realistic so that the participants will act as if it's a more real environment. So next slide, please. We use a lot of moulage. On the bottom slide, you can see a wound in that patient's chest, mimicking something that a trauma surgeon would need to respond to, or a trauma team, the nurses and the RTs as well, not just the surgeon. So next slide, please. And this is one of the task training things that Dr. Snyder had alluded to earlier, where they can practice these central lines, which are so important to practice. Using ultrasound to insert those has a much higher success rate. And so doing that training prior to doing it on a real person is so important. Next slide, please. Again, this is a central line that we use for cooling patients after cardiopulmonary arrest. And so it's uber important to practice that as well. Any words on that?
Yeah, it's just really, really important things that you don't do frequently. The way to get better at it is by practicing it.
Yeah, you can go to the next slide. Thank you. This is a program. It's called a cardio. What is it?
Code open.
Code open, for short. Yeah, it's cardiothoracic surgery after cardiothoracic surgery. So after they have had some bypass surgery and they have difficulties with their vessel leaking or air trapped in the chest, the surgeon's got to go back in, and it's usually an emergency, and relieve the pressure on the heart. And so this is a whole ballet of procedures that get strung together in a streamlined fashion, and we have to practice it so that the surgeon can get in there as quickly as possible to relieve that. Otherwise, there can be bad consequences. Next slide, please. We also take it on the road. Speaking of taking it on the road, what do you think?
So the hospital environment is great for the nurses and physicians that work there. We know where everything is, the patient's in a particular place, our supplies are in a particular place, and everything is the same. Everything's almost the same every day. But a lot of healthcare providers don't work in a hospital. They're paramedics or EMTs, and they are out in the field. So they need to know how to take care of patients on the side of the road, in a bathroom, in a helicopter, on an escalator. And so for that reason, we will take our robots on the road, take them out and have our patients, have a heart attack and then get picked up by a helicopter, have a seizure in the middle of the mall. And so our healthcare providers have to deliver the care there. Yeah, it's more stressful. Yes, it's more difficult, but it's less difficult if you've drilled it before you have to do it in real life.
Exactly. And we often do this to test procedures for getting patients from one place to another. So logistics is a lot of the challenges for moving patients from A to B. And so we can test that in a simulation environment. So next slide, please. So we have kind of two separate missions here at WakeMed. One is to provide education and training, and the other is to test processes, like I alluded to in that last slide. We teach our education with just nurses, or we incorporate nurses, physicians, and RTs. We can do skills validations. One of our departments has a pre-practice boarding process where they go through their initial employee orientation, and then they come here for a summative event to say, we're going to test you on all the things you learned during the last 12 weeks of your employment, just to make sure that it's okay to set you free to do some practice, out on your own. And so we do that kind of stuff occasionally as well. And for process-driven stuff that we do, so we have lots of different emergency code responses in the hospital, and one of them is a code blue, where the patient is having, or somebody is having, cardiopulmonary arrest. And so we drill that in the hospital because it's an important thing to get right. And so we can make sure that the responding teams are following policy and procedure. We can point out areas where there's a potential for improvement, or for, kind of ways that people can I don't even know what I'm trying to say. Evidence-based practice kind of, I'm fumbling over my words here. Help me out, Dr. Snyder.
But you can read in a book, or you can make a plan for how you think something will probably work, but you don't really know how it's going to actually work until you physically go through the process. So when we hear an idea like, hey, maybe we should start doing this surgery in the emergency room, or instead of in the operating room, maybe we should give this new medicine that we've never given before. Well, you can talk about it and write it down and see what you think is going to happen, but it's only when you drill it that you know how the things actually work. And so for important things like what's going to happen if we have a big emergency and we have 15 people who come in with injuries from a fire, well, we think we know what would happen, but just to be sure, we'll drill it ahead of time.
Excellent. Thank you for helping me out with that. Next slide, please. So advances in simulation. Here you can see a clear linear advancement of simulation in the military. Here they had the horse simulator from back in the old days when we had cavalry, to probably somewhere around the 80s, 90s, where they used to practice with infrared targeting systems for weapons. And now we're in the virtual environment where you can see those little circles where the soldiers are standing on. And those are to keep them safe, because they are in an immersive environment and they cannot see the room around them or the people around them. And so what they're seeing in their eyes is probably either a forest somewhere or a desert somewhere. They don't see the walls around them or the people around them. So that's kind of a heavy duty, high fidelity simulation right there. And that's where we're going. So next slide, please. Same kind of idea here. So virtual simulation for medical practice to give us a better idea of what we're doing at the patient's bedside. Here on the top slide, you can see a real person interacting with an avatar. And she's probably doing some kind of a surgical procedure on that patient. She gets to practice that on that, in that environment for the first time sometimes. And so when she goes to see it in real life, again, it's going to be second nature because she's already done it. So thank you. Next slide. These are the national organizations that support simulation in healthcare. If anybody's interested in perusing some of the articles on simulation, some of the evidence-based practices that are incorporated in simulation, they'll be on these websites. Next slide, please. And I think that's going to take us to our video. So this is a video of simulation that happened here in our simulation center. It's kind of choppy a little bit, and that I took out some of the parts that weren't really all that relevant to shorten the video. This would have been probably a 30-minute video if I had cut it down, but these are some of our medical residents doing a simulation in our sim center.
Okay. This is Mr. Make It. He presented to the emergency department today with several of his friends. They were just really concerned about him. They brought him in because he was confused and wasn't acting right. He had complained of just overall pain last evening before going to bed and took some Tylenol. The ED is really busy right now. They just know this guy's going to need admission, so they wanted you guys to come down here and admit him.
Okay. How old is he?
17.
Okay. Hey, Mr. Make It, what's going on?
Hey, how are you?
Good, how are you? Tell me what you're feeling.
My head hurts.
Okay, when did it start? Can we get some like
I don't know.
Get some levels.
I had a sore throat last night before I went to bed, and my head kind of hurt, so I took a Tylenol and went to bed. And this morning it's just a lot worse, and I don't know. They say I'm not acting right.
Were you doing anything in particular last night?
Can we get
Or were you just
No,
hanging out in
I was
halls?
studying.
Studying?
Oh, you need labs?
Yeah, is that okay?
All right, sure, yeah.
Sorry, what
He was just studying.
You were just studying, you felt like a headache. Are you having any like blurry vision?
I haven't really noticed.
Okay. Are you feeling short of breath? Are you having any chest pain?
No chest pain. Just my head hurts and my legs hurt, my arm hurts, everything hurts.
Everything hurts. Okay.
All right.
Has this ever happened to you before?
Get labs?
Yes.
Do I need to manual this blood pressure?
No, you're good.
Okay.
You just say, you can just verbalize.
Has this ever happened to you before, Mr. Meekett?
Yeah.
No,
Yeah, I
I'm
can.
usually pretty healthy.
Blood
Okay.
pressure cuff
Any-
is going.
Any past medical history, like any other conditions that you have?
No, I'm a soccer player.
I'm
I'm in
gonna say
good
labs
shape.
will be drawn.
Okay, good.
Labs are drawn.
Any drinking?
No trouble breathing. My head just really hurts.
Do you drink alcohol?
No, not really.
No.
Not really? What does that mean?
For more than any other high school kid you know.
How much do you usually drink in a day?
No, I don't drink. I've drank twice ever.
Twice ever, okay.
Smoking?
No.
No smoking, no marijuana.
Oh, none of that stuff. I got a scholarship that I've got to keep.
That's awesome.
His
How about
temp- His temp is
vaccinations?
104.1.
Okay.
Are you up to date on all your vaccinations?
Have to ask my mom.
He's
Out of
tapping
10.
He's a little hyper.
Was anybody sick around you the last couple days?
Fluids, yep. Blood.
Not that I know
I
of.
got blood
Not
cultures
that you
lab.
know of?
Okay. I got electric.
Yep, everything's
I already
done.
got the
Labs are
cultures.
set.
Okay, maybe give him like a.
He's very hypotensive.
I'm gonna move the bed, y'all.
She's hypotensive now. So we gotta squeeze in the fluid
What about a
really fast.
A pressure? All right, it's going
Can we get a
fast.
pressure bag for the
Yes,
fluid?
yeah.
Pressure bag and then.
Why?
We're gonna pretend that
Yeah.
it's the pressure bag,
Squeezing,
yeah.
yeah.
It's squeezing right now.
Squeezing right now.
So it's responsive
It's like a
to.
cart. I mean, if it's stable, it's hard to tell. It's
Yeah, I mean, he's in sinus attack though, right?
Sinus tach with a pulse.
Like pretty version isn't.
Well, he's not in AFib.
He's not an AFib.
But
No,
it could get.
you could do this, like vagal and then do adenosine.
It might just be a reaction from like him being super sick.
Yeah. If he's actively seizing, we'll
Did we get any of his,
Ativan.
Can we get a
lab work
CK
yet?
and the lab work come back? What's
lab
his white blood cells?
Lab work is still pending.
Why
Did we get the CT head?
He did not get the CT.
What's his
He
temperature?
didn't get it
Not
yet?
yet.
What's
104.1.
Is he seizing?
And we have the antibiotics are going.
Did we get Vanc and Cepapine on him already?
Okay.
Lactate was 4.5.
Okay. So we're essentially treating him already for septic shock. How about the EKG? We got the EKG. How about the chest X-ray?
Chest X-ray is normal.
Head CT.
Head CT came back as normal.
Okay.
I mean, I think.
So we do.
We can do
we
we need to slow down.
You should do a lumbar puncture.
Yeah, LP before.
Then we call the ICU.
Yeah,
He's not.
You said you wanted to do a lumbar pad? No, that's not stable. Oh, okay. Yeah. So the 30 days for kids, right? Yeah.
Sounds like a party.
It sounds just like a party, yeah. And this is to help us see if you have meningitis, which is inflammation around your brain, okay?
Do you want the bed higher a little bit? You're good.
Yes, please.
Let me know when you're good. That's good?
That's good.
Oh, blood pressure is good. You saved him. You fixed him, I assume.
Plastic sheath off, yep. And then make sure your stylet is smooth and comes in and out. Perfect.
Yep.
Okay. And then find your placement.
If I'm sterile, can I touch
You are
this
sterile.
again?
You can touch it again.
So she's doing a spinal tap maybe for the very first time.
You shouldn't feel
It
anything
becomes
here.
really obvious why you'd want to see someone practice it on a simulator before a person put a needle that size in your back.
Why? I'm like, why is it working?
All right, good.
Okay, so now,
Are you still holding that?
yes.
Yeah, perfect. All right. So turn it one more. Yep. So you're off to here. This is awkward. You're gonna grab your first tube because this is your first sample.
Can I get some assistance?
They would have to be sterile.
Oh, yeah.
Someone
Someone else. It's just me.
I do recommend that somebody else, while you're doing all of this, has sterile gloves on and helps, okay? And now, because you're gonna want them to flip that over, because you're gonna want this sample that's in here to be your first sample, okay? So then it would release into that tube, and then you can remove.
I think I tapped him dry.
And that would be okay until you get the legit one, or you have to get like the formal?
It's fine for you to do it at the bedside, but I would still go ahead and get the formal. Yep. All right, great. So talk about the seizure versus shiver.
Oh god.
I couldn't tell on him.
I
I've never
think we
seen
all
him
kind of
seize before.
forgot that he was also 104.
Yeah.
Like febrile kind of seizure.
Yeah, I mean, I was just thinking about the mannequin. Like, I figured they wouldn't have had him shaking if it was not a seizure. But I mean, we didn't know what a seizure was supposed to look like.
Yeah.
Yep.
Yeah.
Yep. So in him with his temperature, they can sometimes look similar, okay? It was supposed to be, I guess, more tonic-clonic, but what's the difference as well? What else
He
was
was
you
responding
thinking?
to
Yeah.
us. He didn't respond to us.
He wasn't responding at all throughout any of that. So treatment was correct, perfect. Ativan stopped the seizure. All right, let's go over also your infectious causes.
So as you can see, like in that case, you know, they did a lot of things well. They could have done a lot of things better. And right after the student have gone through that experience, their brains are wide open to learn more knowledge. Like sometimes you learn things, it's dry or kind of boring. Like, when am I ever going to use that? Is a question people ask themselves. Right after you've done a simulation where you may not have known what to do, or worse yet, you made a mistake, that's a time when your brain is just thirsty for knowledge, and those teaching lessons can sink in and be with you for a lifetime.
So we're open to fielding questions if anybody has any.
Yeah, if you have questions, you can go ahead and drop them in the chat. I had a quick question. What advancements in simulation do you guys foresee in the next 5-10 years, especially with the VR side of it?
So virtual reality and augmented reality are kind of the two of the big topics that are being explored and improved recently. There are some available now. They're really geared towards academic centers, but we are seeing a lot more advancements in those types of simulation recently, and I think that's kind of where the future is going to go, just making things better. We've seen our simulators be able to do things that they could never do before, and so, you know, we're just looking forward to how we can integrate virtual reality, augmented reality into our system here. Dr. Snyder.
Yeah, it's there's the cost of the physical simulators is so staggeringly high. Each little robot costs usually around $100,000 each, and every time they break, that's another $5,000, $10,000, $15,000. And it also requires a lot of space, a lot of manpower, a lot of programming, and a lot of time. And there's only so many people we can get around a single simulator at once. Versus once virtual reality gets to a point where it's more realistic, then we'll be able to teach broad expanses of people, and cost will go down, which will make it easier to teach more people quicker.
And so I think COVID-19 probably brought to the forefront of our practice the realities of moving things to a virtual environment. Dr. Snyder and the team here at the Medical Simulation Center did our first virtual simulation because of COVID-19, and it was a huge success. We had a team that put together a video of a simulation, and then we had people who were doing, just a simple Zoom meeting, and presented the case to them and did a scenario and debriefing, and it was a monster success. People loved it.
Yeah, so I saw a couple of questions in the chat. One of the questions was, do you use old equipment, to practice with, or do you use the newer equipment? And it might surprise you. Older equipment is nice because it's cheap, but whenever possible, we try to use brand new equipment, even though we don't like to spend money, but we want our providers to be training on the things they're actually going to be using in real life. So they don't get used to a stick shift car when they're going to be having an automatic, that sort of thing. I saw another question was that other than simulation, what other ways to get healthcare future workers ready to get, I assume that means to get, how could you get ready for a career in healthcare? Well, number one is you got to make sure you want to do it. And the best way to know you want to do it is to get exposed to it, whether that means, volunteering at a medical practice or, taking coursework on those subjects. The more you can get to know whether it's for you or not, that's the most important thing. And there are a million different kinds of jobs out there. You want to choose one that you love, one that inspires you, because that'll give you a lifetime of happiness.
Oh, that's a great topic.
Oh boy.
Simulations for mental health crises. Yeah, we are actually working on a new educational program as we speak, on dealing with this very topic. So yes, we do have simulations in our planning, some simulations for the near future on how we can better respond to these crises.
Yeah, and we do that, using a combination, of actors as well as simulators in some manner. The mental health crisis of the United States is substantial and in many ways has not been addressed as well as it could have by the healthcare system. And so anything we can do to make nurses and doctors and paramedics better in managing these patients is good for everyone. Hey, we really enjoyed it. Thank you, guys.
Yeah. Are there any more questions or?
I didn't mean to cut you off. I thought you guys had to head out.
Okay, yeah, I think we can go ahead and wrap up because we're a little bit over time anyway. Thank you guys so much. Thank you, Dr. Snyder and Mr. Parrish, for joining us today.
Absolutely, it's a pleasure.
You're welcome. I love being here.
A reminder to the teachers to please have your students fill out those feedback surveys we sent you. If you guys have any questions later, go ahead and send them to Ms. Robin Mooring and we will forward them on to you all. Thank you guys again so much for joining us today.
It was a pleasure.
Awesome. Okay. Everyone have a good day.